Hello, everyone. I'm so happy to be back and to talk about this interesting and relevant topic nowadays, right? Antidepressants. All that you need to know about antidepressants, okay? So, this is the part one of medications in psychiatry, right? Psychiatry is more than depression and anxiety, but we're gonna start talking about these two conditions, how we treat them, and what are the options that we have, how to approach patients who are having symptoms of depression and anxiety. We have six groups, but actually there are five groups, and the sixth group is others. Okay, so others will be mirtazapine, trazodone, and we have the vortioxetine. The first group and the most popular because it's the most used and is our first option for whatever type of depression and anxiety we are facing. So this group SSRIs, we have paroxetine, we have fluoxetine, sertraline, citalopram, escitalopram, and fluoxamine. Okay, this group is very important to know about what are the common indications, what are the common side effects, because this is going to be our first choice. But if we have a patient who cannot tolerate insomnia or he cannot tolerate nausea, we need to be aware of the side effects to be able to communicate to the patient about that, right? So the patient is aware of and can make an informed decision. Now we have the SNRIs. We have the lafaxine and duloxetine. TCAs, we have amitriptyline, nortriptyline, and we have clomipramine. MAOIs, we have phenelcine and tranylcypromide. The NDRI, we have bupropion and others, as I mentioned before. Let's talk about the SSRIs. In first place, we have fluoxetine. This medication has a long life. That means we don't need to taper up or taper down the medication. Okay, we usually start on the dose that we're gonna, the therapeutic dose, right? Another important thing, this is the only medication that is accepted uh, for the drug agencies to be given to kids and adolescents. Sertraline is the first option for OCD as well as clomipramine. This also is preferred in women that are lactating. So sertraline and paroxetine are the drugs of choice if we have a woman that is lactating and is suffering of depression and or anxiety. Then we have citalopram. Citalopram and escitalopram. They are very well tolerated medications, but we have to take into consideration that can prolong the QT, which sometimes we recommend to do an electrocardiogram before starting this medication. In the case of paroxetine, we have more gait gain than the rest of the SSRIs, right? So it's something to consider. As well, for sexual side effects, fluoxetine and sertraline have less incidence, and but on the other hand, paroxetine has the greatest incidence of sexual dysfunction. So this is something important to keep in mind when prescribing an SSRI. We have the SNRIs. We have duloxetine and we have venlafaxine. These two medications may sound familiar to you because we use them as well for neuropathic pain, right? most commonly in people with diabetes who have developed some complications in the nerves, right? We have a different kind of dose if we use them for depression or if we use them for neuropathic pain. But actually, it can be very similar dose for either way, for either depression or neuropathic pain. So, with this being said, if we have a patient who is suffering depression and is having symptoms of neuropathic pain, we may prefer to start with this medication, right? Because we are treating two things instead of one, or instead of using two medications, right? So that's why this group is preferred in people who have comorbidities and this in the sense of neuropathic pain. Now we have the TCAs, and these ones we have amitriptyline, nortriptyline, and clomipramine. Okay. Again, amitriptyline and nortriptyline are also used for neuropathic pain, not clomipramine. This is not a medication that we use for neuropathic pain. Okay. The depression dose and the neuropathic dose, it can change a little bit comparing to the group that we saw before, because, for example, in depression we use a dose of, in amitriptyline we use a dose of 75 to 150 milligrams a day, and for neuropathic pain we use a lower dose, so we can start as low as 10 milligrams to the highest dose that it will be 75 milligrams. Okay. Kind of the same with nortriptyline. The depression dose, the therapeutic dose for depression is 50 to 150, and for neuropathic pain is 10 to 75. So it tends to be a lower dose that when we use it. Tends to be a lower dose for neuropathic pain comparing to when we use it for depression. That's what I'm trying to say. Now, clomipramine, this is a medication that is also a first line for OCD, okay? The thing with this group in general, the TCAs, is this group has a higher risk of anticholinergic and cardiovascular side effects, okay? This medication, it's it's our last option for people with depression, okay? Because with this medication, you can actually die of overdose. We don't want to give a medication to a patient who is suffering of depression and or have suicidal attempts, ideation, because if they overdose with TCAs, they can actually die. So we tend to leave this group at the very end of our options. Now we have the MAOIs. This is phenelcine, and we have the tranexapramine. So phenelcine, we can use it, and it's 45 to 90 milligrams a day. That's the dose that we can use, and we divide it in 2 or 3 doses. Okay. This is, again, not the first, not even the second option most of the times. This has very bothersome side effects for people with depression. We know that people with depression, they tend to sleep more, and these medications tend to increase that, right? They have a prominent hypersomnia, they have increase of appetite. So these are not the ideal for patients with depression, but it can work well in certain groups. Now we have the NDRI, the most representative medication here, and pretty much the only one that we have is bupropion. Okay, this medication is very well accepted for other conditions, for example, for smoking cessation, in depression, and this medication is the one that has the lowest sexual dysfunction rates when we talk about antidepressants. Okay, so if we have a patient who is taking an SSRI and said, you know what, I cannot tolerate this medication because of the sexual side effects. Can I have a medication that won't give me those? We can think in bupropion, okay, as a medication to switch. So this is very well for depression with prominent fatigue or low energy, okay, or depression that comes with hypersomnia or weight gain. Also, people who are trying to, or not trying, but already decide to stop smoking and they have depression, this medication works very well. We give this medication for people who are stop smoking because will reduce the cravings for smoking. That's why we do this medication, right? So if we have a patient with side effects of sexual dysfunction and has depression and or wants to stop smoking and is like already decided, we can give this medication. It will be our first option, um, or one of our first options, right? Because we're gonna talk about, for example, mirtazapine also has lower sexual side effects. Okay, so mirtazapine, it can be given 15 milligrams to 45 milligrams a day. Okay, this it will help with depression who are having some features of insomnia, poor sleep, or weight loss, or poor appetite. So if we have a patient with depression and is showing these features, this patient can be this medication can be feasible to give. Now, trazodone is a very old antidepressant medication, but works really well with people who are struggling with insomnia or sleep disturbances in general due to depression. So, of course, this is given at bedtime, right? And mostly, and again, in people who have problems with sleeping, and they are those problems are caused by depression. Now, the common side effects. So when a patient comes to us and the patient has the criteria for depression or anxiety, we are talking about what medication can be suitable for them, for the patient, right? And this is an individual assessment that we do, right? And mainly goes or it's mainly done by what type of condition you have, what is your most prevalent, or not prevalent, but most bothersome symptom for you, right? And also if you have any contraindications that can be which will make me think and you need another medication instead of the first line, and if you are okay with the side effects. So there are three things, right? What type of condition you have, including symptoms, the most bothersome symptoms for you. Oh, I have depression, but I hate that I'm sleeping all day. Okay, so that's something important for us to acknowledge. Secondly, do you have any other comorbidities or contraindications that can't stop me for giving you that medication? And the third and last one is, are you okay with the side effects that can come with the medication that I want to give you? So these three things, three points are very important to discuss with the patient, okay? And also tell the patient that if this medication doesn't work, we have many others to try. A lot of people with depression that I have talked to, they are concerned, they are so frustrated because they were given a medication and didn't work. So they are like, oh my God, am I not gonna be able to get off this depression? Am I have to suffer for this uh, of this for all the time? And the answer is no. We have a lot of medications to try before we get to a point where we said, you know what, you know what, sorry, you are a refractory type of depression. We need to assess you for another types of treatments. But that's the last resource, right? It's the very end, um, and it will not come after at least 6 months or a year with the patient following the treatments, the medications, and again, using CBT therapy, for example, right? So, common side effects we have for SSRIs: the sexual dysfunction, diarrhea, tremor, headache, nausea, insomnia, and some somnolence. Okay, most of the side effects they go away within the first 3 months. Okay, we can include medication, for example, for diarrhea, loperamide for diarrhea in our prescription, because it's common that you will present it. So in case that you present diarrhea, you can take this medication. Okay, or in case that you present headache, you can take Tylenol. Okay, or if you are presenting headache, please approach to me and we will address that. But I have seen that some prescriptions include the treatment for the most common side effects of the medication that you are prescribing, right? Which I think it's at certain level a good approach, a good way to deal with those common side effects. SNRIs, venlafaxine, and duloxetine, we pretty much have the similars: nausea, insomnia, but also we can have dizziness, sweating, and increase of blood pressure. Okay, which has to be careful evaluated if the patient has hypertension, right? Because we may do some changes in the treatment of hypertension, and this is a temporarily increase of the blood pressure. Okay, so just be careful when assessing these side effects. Now, TCAs, again, we don't like it very much. We leave it at the end most of the times in people with isolated depression because of the very, very severe and side effects. Okay, we can have orthostatic hypotension, we can have weight gain, we can have blurry vision, dry mouth, constipation. These are most commonly or are done by the anticholinergic effects, right? Urinary retention, sedation, those are very concerning side effects if presented. Okay, and besides that, we can have the risk of overdose, which can result in death, because this medication in overdose can kill you. Okay, then we have the MAOIs. These are also can cause orthostatic hypotension as the TCAs. They can cause weight gain, insomnia, sexual dysfunction, hypertensive crisis with tyramine rich foods. And then we have the atypical that we talk about it. This one, they are including bupropion here. Okay, remember, atypical, we can say that bupropion and mirtazapine, they have the lesser side effects regarding sexual dysfunction. So these are this group are preferred option if the concerning or the patient presented with sexual dysfunction and is going to stop the medication because they cannot deal with that. It's too bothersome for them. Okay. this one is very important. Bupropion increases the seizure threshold. So if you have a condition that gives you a risk, or you have epilepsy, bupropion is totally contraindicated. Okay, this is very important to mention. If we have a patient with anorexia and depression, bupropion is contraindicated. Regarding mirtazapine, we have sedation, weight gain, and increased appetite. So, how to choose the right medication for your patient? I have developed a little bit of a step-by-step approach. First, does the patient fits the criteria for depression plus less anxiety? We have the DSM-5, which it's the book that we base on to diagnose these conditions, right? So once that we said, okay, this patient fits the criteria, now the second question, it's gonna be, does the patient has any comorbidities such as diabetic neuropathy, right? The third question, sorry, will be, is there a first line for the condition we intend to treat? And the last one is review contraindications, discuss possible side effects, and make a decision with the patient. Okay? If there is no contraindication or specifications, you have a patient that is 32 years old, pretty healthy, no conditions, we prefer to start with a trial of SSRI, okay? That's the way to go. But again, not all the patients will be healthy, will be with no contraindications or accepting the possible side effects, right? So this is an individual decision that we should make with our patients. Now, again, let's do a little bit of an example case. So if you have a patient that fits with the SIGE caps, right? We have that sleep, increases sleep. We know this what SIGA caps means, right? We are doctors. So if it fits that, and is, for example, we have a major depressive disorder diagnosis. Now, if it's a 38-year-old male with dyslipidemia, the first option will be so far SSRI, right? And we talked to the patient. We said, you know what, because of your condition, your symptoms, and you are, besides dyslipidemia, you are pretty healthy, I would like to start with SSRI. There's a group of medications that work really well for depression, and it's our first option for that. However, the side effects include this, and this. And when we mention sexual dysfunctions, both men and women, they tend to be like, I don't know if I want to try it because I'm concerned about the possible side effects, right? We can advise why we don't try the medication that in this group, in the group of SSRI, has the lowest risk or the lowest incidence of sexual dysfunction. Would you be able to try it? And if they say yes, you can start, for example, as we mentioned, fluoxetine and sertraline. They have the less incidence in the group of SSRIs of causing sexual dysfunction. So we can try with that and see how the patient is doing. And they may not even develop any sexual dysfunction, right? So that will be my approach, my suggested approach for you. Now, when should I evaluate the response of a treatment given? This is a very common question, if not that you will need to answer. You need to ask yourself, right? Because if you have a patient who is having, for example, suicidal ideation, you're not gonna start the antidepressants and send the patient home, right? You need to evaluate the patient, and probably they will need to be hospitalized for at least 48 hours, depending on where you are in the world. But you cannot just give antidepressant and hope for the best, right? Because the response, we have that the relief of neurovegetative physical symptoms takes between 1 to 3 weeks. So if they are with hypersomnia and if they are with irritability, it will take weeks before they can notice some changes, right? And the most important, or the most not important, but the emotional and cognitive symptoms that which are more concerning for them, it takes between 2 to 6 weeks. So there is a lot of time before the patient can start noticing the changes, right? So we need to tell them, because if we don't tell them that after 3-5 days taking the medication, they're gonna think this isn't working, right? And they stop taking the medication, etc. So we need to inform, we need to be careful about that as well. And there is another thing, tapering down the medications. Pretty much most or all of the antidepressants, except fluoxetine, needs to taper down or taper up. Okay, if we don't do that, it can cause withdrawal reactions, which are usually the symptoms of a cold, but still we should be careful with these medications. So, for example, if we have a patient that is taking sertraline, and the patient started with 25 milligrams, then it went to 50, the therapeutic dose, but after 2-3 months, the patient doesn't notice any improvement, we can taper down the medication, and at the same time start with the other one. And we can start, for example, with citalopram. So we can start with 10 milligrams of citalopram, taper down the sertraline, and at some point we're gonna increase the citalopram. There are a few different taper up and down formulations or suggestions, depending if the patient has renal failure, liver failure, or other comorbidities, right? But this is in general sense, we need to taper down and start tapering up the medication that we want to switch to. And that's it. So thank you very much for your patience, and also for being here with me and allow me to teach you about this highly important topic nowadays. Thank you.